In this video, we're going to be talking about pulmonary ventilation. Really, this is the first respiratory physiology video, so you could also think of it as respiratory physiology number 1. By pulmonary ventilation, you can also think of it as basically being inhalation and exhalation. Ventilation is filling your lungs with air and expelling that air. Now, since this is our first respiratory physiology video, let's talk a little bit about the different processes involved in respiratory function. The overarching function of the respiratory system is pretty straightforward. Oxygen in, carbon dioxide out. You need oxygen in order to do cellular metabolism, in order to make enough ATP for your cells to continue to function. And when your cells make that ATP, they produce carbon dioxide, and that carbon dioxide needs to be expelled from the body. So your lungs really serve these two purposes. Of course, it's really not quite that simple, and there are actually 4 processes involved in getting oxygen into your body to the cells that need it, and getting that carbon dioxide back out. The first one, ventilation, is what this video focuses on, and ventilation is just moving air in and out of lungs. Next, you have external respiration. Now, the term respiration, when you're speaking about respiratory physiology, respiration refers to the movement of oxygen and carbon dioxide in and out of the blood. So external respiration is the respiration that happens in the lungs. And so in the lungs, you have oxygen moving from the lungs to the blood, and you have carbon dioxide moving from the blood to the lungs. So external respiration happens at the lungs. Internal respiration happens at the internal tissues. And for the exchange of gases in internal respiration, you have oxygen moving out of the blood into the tissues, and carbon dioxide moving from the tissues into the blood. In between the lungs and the tissues, in between external respiration and internal respiration, you need to get those respiratory gases, get that oxygen and carbon dioxide to where they're going. So it's basically transport of oxygen and carbon dioxide in the blood, how they're carried in the blood. We'll talk about each of these processes individually. For this first video, we're focusing on ventilation. In order to understand what's happening when we breathe, when we're pulling air into our lungs and expelling that air back out, we need to discuss a little bit of physics. Now, there's a principle in physics called Boyle's law. This boils down to basically, no pun intended, it boils down to basically gases always fill their container. Okay, so Boyle's law is an analysis of the movement of particles in a gaseous state. P in Boyle's law stands for pressure, and V stands for volume. By P1 V1 equaling P2 V2, what basically you need to know about this is that as the volume of a chamber goes up, the pressure of the gas within that chamber goes down. And vice versa. As the volume of a chamber decreases, the pressure of a gas within that chamber increases. Now, this illustration over here illustrates why that is. Basically, if you have gas in a box, in an enclosed space, you have a set number of molecules in this enclosed space. All right? Now, if you take this enclosed space and you compress it down into a smaller volume, you still have the same number of molecules in there. The molecules can't escape. They can't go anywhere, but they've been compressed. So now you have the same number of molecules in less volume. They're all pressed together, they're closer to one another, they're bouncing off each other, and they're going to hit the walls of the container more frequently. It's a higher pressure situation. Right? So here we're seeing decreased volume giving you higher pressure. Now if you take the opposite situation, same container, same set number of molecules, and you increase the volume of that container, so you pull those walls out, you open it up, the molecules are now more spread out. There's more space between them. They're bouncing into each other less and less and less. So you get, with an increased volume, you get a decreased pressure. If I were graphing this relationship out, I would put pressure on the x-axis, volume on the y-axis, and the actual graph of this relationship would look something like that. I want to show you a quick animation put together by an educational website from NASA that will illustrate this relationship. You can see at this point the chamber is fully expanded, volume is at its highest, and pressure is at its lowest. At this point, the chamber is fully compressed, volume is at its smallest, and pressure is at its highest. So high volume equals low pressure, low volume equals high pressure. This is Boyle's law. Now I want to take just a couple steps further to relate this to what's going on when you breathe. Molecules move from an area of high pressure to low pressure. All right, molecules move from an area of high pressure to an area of low pressure, if they can. Now, in these boxes over here, so far we've been talking about them as enclosed spaces. There's nowhere for the molecules to escape, so the molecules are trapped. Nothing can come in and nothing can get out. So what's going to happen when we open a pathway? Now, let's imagine that this box over here, this is our atmospheric pressure. This is the outside air. So over here, where the box has been compressed, the pressure is higher, so the pressure is greater than the outside air. Now, molecules move from an area of high pressure to an area of low pressure. So if you open a hole in this box, molecules are going to move from the area of high pressure to the area of lower pressure. They're going to leave. In this box, where the volume has been increased and the pressure has dropped below the outside atmospheric pressure, when you open up a pathway to that box, molecules from the outside are going to move in because they'll be moving from the area of high pressure to the area of lower pressure. This top situation, this is kind of like what's happening when you exhale. It pretty much is what's happening when you exhale. When you're exhaling, you're compressing your thoracic cavity. You're decreasing the volume of that chamber, and air gets forced out. This bottom box, this is the situation when you're inhaling. You are opening up your thoracic cavity, you're increasing the volume of your thoracic cavity, lowering the pressure in your lungs, and air gets drawn in. If you'd like to really get a sense of this, bear with me for a moment. Close your mouth, hold your nose, take a deep breath. Now let go of your nose. Did you feel the air rush in? That's Boyle's law as applied to breathing. So understanding the pressures in the thoracic cavity is pretty important to understanding what's going on when you are inhaling and exhaling. These respiratory pressures, they're always expressed relative to atmospheric pressure. Atmospheric pressure is more or less 760 millimeters mercury. It's measured in millimeters mercury, just like blood pressure is. So the respiratory pressures are always expressed relative to atmospheric pressure. So if you see a respiratory pressure of 0, that means that it's equal to atmospheric pressure. If you see a respiratory pressure of -4, that means that it is 4 millimeters mercury less than atmospheric pressure. The pressure on here that is most directly relevant to inhaling and exhaling is the intrapulmonary pressure. Sometimes you'll see that represented as P-pul, P-pulmonary. This is the pressure in the alveoli, the air sacs of your lungs. It rises and falls as you breathe. It equalizes to atmospheric pressure if you have your respiratory tract open. And it's what determines if air will move in or out. If that intrapulmonary pressure is less than the atmospheric pressure, then air is drawn in. If that intrapulmonary pressure is greater than the atmospheric pressure, air will be forced out. You also have a pressure in the pleural cavity. That's called the intrapleural pressure, sometimes represented as PIP. And that's the pressure in the actual space in between your visceral and parietal pleura. So here's your visceral pleura wrapping tightly around the lungs, parietal pleura adhered to the wall of your thoracic cavity, the muscular wall, and the fluid-filled space in between is the pleural cavity. And that is always about 4 millimeters mercury less than the intrapulmonary pressure. The transpulmonary pressure is the difference between these two pressures. So the transpulmonary pressure is the intrapulmonary pressure minus the intrapleural pressure. This transpulmonary pressure, it's important that there's a slight difference between the two because this transpulmonary pressure is what keeps the lungs from collapsing. So basically, you have this tension that is constantly holding your lungs open a little bit so that your lungs never completely collapse, which is a very good thing because it requires much less effort to inhale if your lungs are just ever so slightly open before you try to inhale. If your lungs completely collapsed, it would be, you'd expend most of your energy during the day just trying to breathe. This diagram shows how the intrapulmonary and intrapleural pressure changes as you inhale and exhale over a complete respiratory cycle. And it shows down here how these pressure changes relate to the volume of air in the lungs. When you inhale, you expand your chest. So you are opening up your chest, you're pushing down on the diaphragm, pulling out with your intercostals, expanding your chest. But your chest muscles aren't directly connected to your lungs. Instead, they're connected to the parietal pleura. Okay, so as these muscles expand, the parietal pleura expands out as well. As that chest wall moves outward, it pulls the parietal pleura out, and this has the effect of increasing the volume of the pleural cavity. And as we know from Boyle's law, that means a decrease in the intrapleural pressure. And you see that there. That's what's happening when you are inhaling. As the intrapleural pressure drops, that pulls the visceral pleura out. as well. So as the visceral pleura are pulled out, they're tightly attached to the lung tissue, so the lung tissue gets pulled open. So you have an increase in lung volume, which gives you, by Boyle's law, a decrease in intrapulmonary pressure, like you see there. And as the pulmonary pressure falls, you get air sucked into the lungs, and the volume of air in your lungs rises. Your tidal volume goes up. Now, if you just reverse all of these arrows, you basically have what happens during exhalation. Muscles relax, compressing the pleural cavity. Pressure goes up in the pleural cavity. They push on the lungs, closing the lungs, pressure goes up in the lungs, and air gets forced out. Now, there are two forms of pulmonary ventilation. You can have quiet ventilation. Quiet ventilation is basically how you breathe when you're not thinking about it. Don't think of the pink elephants. Quiet ventilation is just casual, normal breathing. You're not working particularly hard, you're not forcing it. During quiet ventilation, during inhalation, and sometimes inhalation is also called inspiration, you should be familiar with that term. And during quiet inspiration, it's your diaphragm and your external intercostals that are involved. The diaphragm contracts. As the diaphragm contracts, it flattens, so it pulls your lungs down. The external intercostals, as they contract, they pull your chest, your ribs, up and out, expanding your lungs. Quiet exhalation, also called expiration, is an entirely passive process. If you're not thinking about exhaling forcefully, you actually aren't using any muscles on the exhale, only on the inhale. What's happening on the exhale is your muscles are relaxing, and there's enough elasticity in the lungs and in the muscles that they passively recoil, recompressing the lungs and forcing air out. Now, I want to remind you of the intercostals. This is from the muscular system. This is the pattern of the external intercostals. When the external intercostals contract, they pull up, which forces your rib cage up and out, expanding your thoracic cavity. You have this other set of muscles, the internal intercostals, which when they contract, they pull down, forcing your rib cage down and back, compressing your rib cage. The internal intercostals come into play during forced exhalation. Forced ventilation is when you're really trying to either take a deep breath or to force all the air out of your lungs. In forced inspiration, you still have your diaphragm acting, you still have your external intercostals acting, but you get accessory muscles involved as well to increase your thoracic volume even more. Your sternocleidomastoid gets involved, your pectoralis muscles, even your erector spinae muscles that straighten the spine. Try taking a deep breath and feel what happens to your spine. It straightens up, doesn't it? In forced expiration is an active process. Remember, quiet expiration is passive, but if you really want to get all the air out of your lungs, you need to actively use some muscles. The abdominal muscles come into play. So what you're doing when you contract your abdominal muscles, you are compressing the contents of your abdomen, your abdominal organs. You're compressing it up against the diaphragm, forcing the diaphragm even further up. This is also where you get your internal intercostals involved. Your internal intercostals compressing your rib cage, forcing just a little bit more air out. If you've ever done any voice training, like for acting or for singing, they always tell you to sing from your abdomen. That's because you have much better control over your abdominal muscles. So if you're using your abdominal muscles, you can get if you practice, you can get really fine, extended control over your exhalations. There are a number of different factors that affect ventilation, and we'll have another video that talks a little bit about neural and chemical regulation of ventilation. But in general, focusing just on what's going on in the lungs, airway resistance plays a role, alveolar surface tension, and what's called lung compliance. Airway resistance is important in the same way that resistance in the cardiovascular system is important. If you have increased resistance, you have decreased airflow, and resistance can occur as a result of changes in bronchial diameter. So if the bronchiole is smaller, you have more resistance and less airflow. If the bronchiole is fully dilated, you have less resistance and better airflow. So if you know anyone, or if you have yourself have asthma, asthma is where you have an inappropriate inflammatory reaction that causes the bronchioles to constrict, which greatly increases your resistance and decreases your airflow, an unpleasant experience. Now, surface tension comes into play because you have watery fluid in your alveoli. You have this kind of a thin, watery fluid coating the cells, the surfaces of those air sacs. And like watery fluids do, this fluid normally has a high surface tension. This high surface tension of water, that's why you can get water climbing up a narrow glass tube. That's why you can get water striders walking on the surface of water. There's a lot of attraction between molecules in water that tends to, those molecules tend to like to hold on to each other. And that surface tension would tend to pull the alveoli closed. Now, like we talked about with transpulmonary tension holding your lungs open, if your alveoli close completely, it's very, very difficult to fully reopen them. You expend a lot of energy just taking a breath. Now, thankfully, you have cells in your alveoli, the type 2 alveolar cells, that produce a substance called surfactant. Surfactant is a molecule that is both hydrophobic and hydrophilic. So it acts a little bit like a detergent. It's got a hydrophobic region, or hydrophilic region, and then a hydrophobic region. And it sits over the surface of over the surface of the fluid in your alveoli, reducing the surface tension. Clinically speaking, surfactant production is an important consideration in the neonatal intensive care unit because surfactant production usually only begins a few weeks before birth. Why make surfactant when the lungs aren't inflated anyways? You're not using your lungs until you're born. So, premature newborns may need to be on a ventilator because they don't produce enough surfactant. And if they don't produce enough surfactant, it requires just too much energy to completely reinflate their lungs. The chest can actually take on a caved-in look because the lungs are collapsed. This is known as infant respiratory distress syndrome. Thankfully, now we understand the importance of surfactant, and we know that a dose of steroids, dexamethasone, can stimulate completion of lung development. So if there's enough warning that a baby needs to be delivered prematurely, they can give the mother a dose of steroids a day or so or two before delivery so that the baby's lungs will finish development and start producing surfactant and hopefully not need to spend as much time on the ventilator. The third factor that affects ventilation that has to do directly with the lungs is lung compliance. And compliance just means the ability of the lungs to expand as transpulmonary pressure rises. So rising transpulmonary pressure means that the intrapleural pressure is dropping, And so the thoracic cavity is expanding. So compliance is important because if the lungs don't expand, you can't get air to move in. The whole thing that's drawing air in is this increase in volume in the lungs, decreasing the pressure. So if the lungs aren't actually expanding, there's no air movement. It depends on a number of different things. So surfactant is one important factor. Because remember, it takes more energy to open up the lungs if they've completely collapsed, if you're fighting water surface tension, and surfactant reduces that surface tension. It also depends on the mobility of the rib cage. If you cannot contract those external intercostal muscles, then you can't expand the thoracic cavity as well. Also, chronic conditions, like chronic inflammation of the lung or scarring of the lungs, called fibrosis, pulmonary fibrosis, can also decrease lung compliance. If you replace some of that nice, flexible, expandable lung tissue with scar tissue, the scar tissue tends to be bound together more tightly, and it impairs expansion of the lungs. There are also some conditions which actually increase compliance, like emphysema. Chronic smokers sometimes develop emphysema, where there is so much damage to the alveoli of the lungs that compliance actually increases. However, because the respiratory membrane has been damaged, there's still minimal gas exchange, or a lot less gas exchange going on, despite the increased compliance. Okay. After studying this video, you should be able to talk about the pressures involved in ventilation, talk about Boyle's law, how it relates to both inhalation and exhalation, explain the different muscles, the passive and active forces that are involved in quiet and forced ventilation. You should also be able to relate these back to Boyle's law and air movement into and out of the lungs. Lastly, talk about the factors that affect ventilation: compliance, surfactant or surface tension, and airway resistance.